Olivier,
Hello, Louis.
good to see you.
Are you okay?
I'm okay. I was a little bit worried.
Why?
Because I tried to get in contact with you the whole day, but no reaction on several channels. But anyway,
No problem. I was in the operating theater this morning.
Okay.
You know, we are taking all the slots available. Actually, it's every day. You know, I'm going to surgery every day for one patient, two patients.
Good. Yeah.
But no problem. Of course. Good.
Good.
So we start in 2 minutes. Huh?
We can start in 2 minutes. We have already 30 participants.
Okay.
Out of, I think, approximately 130, 135 people that have been registered.
Okay.
So good number. Usually, according to my experience, it's half of the registrants that will join.
Sure.
So we can expect about 60, 70 people.
Excellent.
So yeah, there will be a quick introduction from my side,
sure,
as usual, and then the floor is yours.
Okay, Julie, something I would like to ask you, you know, because for me it will be difficult to present, talk, show the slides, and at the same time to look at the chat.
I will observe the chat. Yeah.
Okay, so my proposal would be that you stay with us, you look at, and when you see that there's a good question, just say, Olivier, we have a question from the chat, and then we can discuss together, you see?
Absolutely.
Otherwise, I will miss them. And since we have 2 hours, I think it's good that sometimes you stop me just to discuss. Okay?
Yeah. Also, I have planned maybe a short question and answer at the end of your presentation.
Sure. Or you can also, if you think that when I mention something, you are thinking that maybe we can ask something, but there's no question, you know all the good questions. So you can also make the question by yourself, not telling the people that it's coming from you, but just because it's a good comment.
Good.
Okay?
Will do.
Good.
So let's wait until we start in, let's say, 1 minute.
Okay, no problem. Good.
Okay. Good morning, good afternoon, and good evening for those who are ahead of us in time. I have the pleasure to invite you to this, I think it's the 4th EMS webinar we do in 2021. I have the pleasure to welcome Professor Olivier Traxer from Denon Hospital, Paris. He just came out from the OR, as he said, and told me. So we have now 2 hours for a webinar, and the main topic you could already see in the invitation I have sent to all of you. The main topic is all about lasers, and an overview. He gives an overview about the developments over the past decades. And yeah, just a few rules of this webinar. Please try to mute your microphone when you don't have a question. If there is a question, just use the chat. I will observe the chat, and I will tell Professor Traxler to stop a little bit and to answer these questions. Also, we have a question and answer session right at the beginning, at the end of his talk. So we have 2 hours today, so there will be plenty of time to answer all your questions whenever it needed. So I think we have added a little CV on the invitation, so everyone is aware about you, Olivier. And I will hand over the microphone to you. The stage is yours. Please start.
Thank you, Lee. Thank you. Very, very happy to be with all of you today for this, I hope, interactive webinar. We have 2 hours. So thank you to Uli and EMS to give me the opportunity to have 2 hours to discuss about lasers. I think we can discuss for many, many hours, but really 2 hours for me, it's excellent really to discuss in details laser technology. We will, of course, discuss about the Holmium technology, and we will, of course, discuss about the Thulium fiber technology, and in general, I would say. So again, welcome to all of you. As you said, maybe good morning or good evening for some of you. So if you're okay, if there's no questions to start, I will share my screen. Uli, I think you need to deactivate something, and then I will be able to share my screen.
Okay, let me check.
Yeah, otherwise I cannot. You are probably the, yes.
I'm the host, yes.
I think, yes.
1 sec.
Mm-hmm. Okay, so just in the meantime, yeah, so you will see today that we will rediscuss laser technology, I would say, from the past at present time, and of course, what we will need in the future, because there's no discussion today that even we have very good technologies today, Holmium, Thulium fiber is the new player, but there's also no doubt that we will have new technologies also coming in the near future. So it's not something really fixed, actually, this laser technology, something that we will use more and more, of course, and we will have to compare also the different technologies in between. That's a little bit what we can see today. You probably see everywhere in Twitter or in the different meetings, all the time these comparison between Holmium, Thulium, and we will have more and more comparative evaluation since we have different technologies. So we will have this kind of information, of course, in the near future. Is it okay, you think, Uli? Not yet. I can still not share my screen. Okay.
One second, I tried to fix the problem.
Good. Good.
So try it again, please.
Okay. Now, he said that you, I suppose, you deactivate the system to share the screen by all the participants. So probably you have to deactivate something. I don't know, because to be honest, I never did it, so I cannot help you. I know that this is something you have to fix, but
yeah,
maybe if somebody in the audience know the trick how to
I never had this problem, to be honest.
sure. I've seen few times now, since we do a lot of webinar.
Yeah.
But usually the people, they know perfectly what they have to do, and immediately we can share the screen. But probably you have something to deactivate, because you are supposed to be the one.
I'm the host.
Initiate, yeah, you are the host. So probably you have to choose. Somebody said you have to choose Olivier as host. This. Thank you, Efkan Tunk, if I pronounce well. Great. Yeah, and I hope that all of you are.
So now it should work.
In good as it works. Yeah, perfect. Great, Julie.
Yeah. Okay, the floor is yours. And sorry for the inconvenience.
That's perfect. Thank you, Julie. I gave this talk at the Chinese meeting last weekend, so maybe some of you have already seen most of my slides. I would say, since we are still using, of course, the same document when we are talking about lasers. But again, the good point today, we have plenty of time to explain all the messages that we would like to give you. In introduction, first I have to show you my disclosure. You need to know I'm a consultant for many years for those companies, including EMS. And you know that some of these companies are actually producing a laser technology, Holmium, Thulium. So keep in mind this, actually. There's something, you will see today when we'll discuss. I think there's many nice publications today coming from the lab. We do a lot of lab experiment. I must say that we do it. We have a special laser lab in my university, and we are using this laser lab since more or less 10 years. And I must say that all my fellows, they participate to these lab experiments, and it's very funny. It's nice to go to the lab and to play with the lasers and do some experiment, and of course to produce some good data. And the data that we produce from the lab, I would say they are very good. They are very reliable, very objective. The reason is, this is the lab. In the lab, it's easy to fix an experiment with all the parameters because you control everything. And you just change one parameter. And you see what happens when you do this experiment. So this is the reason why all the results coming from the lab are really nice, very reliable, but we need to keep in mind that it's still the lab. And as I said all the time, the lab is the lab, and the real life is the real life. And the real life means what you do when you are in the operating theater. And most of the time, you cannot completely duplicate what you experiment, what you demonstrate in the lab directly in the operating theater. So when you read actually publications, people are giving good messages, and most of the messages regarding the settings, for example, they will tell you the testing setting is this combination or another one. Maybe it works perfect in the lab, but maybe it's not what we should do in the real life, in the operating theater. So you need all the time to keep in mind that when you read publications with results coming from the lab, it's from the lab. And maybe it's not exactly what we do. I think it's very important because since many years, different teams in the world are making a lot of lab experiments. They are producing a lot of publications, I must say. And sometimes the message is a bit confusing. Confusing because people are thinking that what we demonstrate in the lab is just the truth, is just what we should do. And in fact, it's a little bit different. And during this webinar today, I will illustrate sometimes this difference. Holmium, Thulium, you probably have seen this picture many times. I like all the time to remember, the origins of these two names. I think it's nice. You know that it's coming from this guy. He's a Swedish guy. He was a mineralogist, somebody doing some research. And when he was looking at the erbium, which is another element, he discovered two new elements, holmium and thulium elements. So he was looking to give two names. And since he's a Swedish guy, he gave the name of holmium for the first element, and he gave the name of thulium for the second element. Holmium because it means Holmia in Latin, so it means Stockholm. And thulium because it's coming from Greek, it means Scandinavia. So it's something very logical since he's a Swedish guy. Just to know this. I think it's good to know that. Again, when we are talking about laser, I don't think it's a very good a new message for you, but all the time keep in mind that we are using laser is light. We are using light, and as you know, light is able to burn everything. Of course, we can treat stones. We can also ablate tissue, tumor. We can incise. We can coagulate. We can cut foreign bodies. Light is super powerful, and we can do everything. But you can also damage the collecting system if you are not using this special light in the good way. And again, we will discuss a little bit later what happened actually with thulium fiber, because I'm sure that you have seen since 1 week this problem with thulium fiber regarding ureteral damages. And one company actually has supported a recall regarding one device due to these problems. I can just tell you, and then we will discuss, but for me, the problem is not the technology itself. The technology is safe. The main problem is the way you are using the technology. And I think this is a very, very strong message. And you need to remember that you are using light. Light is dangerous. So if you are not using this technology in the good way, you will produce and you will have complications. There's no discussion on that. So this is also something we need to discuss today. Use the technology in the good way. Okay, don't use all the possibilities of the technology. Sometimes you have to be a little bit modest and to know exactly what you can do with the technology. There's also something we need all the time to remember the people. a very simple definition. It's coming from physics, laser physics. If you consider the energy and frequency, you multiplicate both of them, energy in joules and the frequency in hertz, you obtain what we call the total power. So the joules by the hertz, you obtain the watts. It seems very simple, actually, to give this formula again, because all of us, we know perfectly this formula. But I can really tell you that I'm all the time very surprised to see people, they're confused and they are talking about power when in fact they are thinking energy and vice versa. So all the time, remember that. The second point is, I realized when we started to work in the lab in my institution, I was talking with fantastic engineers making in laser technology. So they were really good people, very high level, scientific people. And when I was discussing with them regarding laser technology, all the time, they were talking to me in terms of energy in joules and in power, in watts. So it means that they said, okay, if we do this experiment, what would you like? What would you like in terms of energy? What would you like in terms of power? And I was telling them that power, I don't care about the power. I can tell you how much energy I would like in terms of joules, but I will also tell you how much frequency I would like. And he said, okay, but it's not logical. We should talk about energy and power. The frequency, we will see the frequency when we fix energy and power. And I was telling them, no, we fix energy and frequency, and then we will see the power. And it was a bit confusing. And I must say that I pushed them for many years to discuss with me in terms of energy and frequency. And since I'm using the Thulium fiber, I must say that I understood now the real problem regarding this power. And now I understand why they are talking about this energy and power. The problem is that when you are using super powerful system like the Thulium fiber or high power Holmium, if you just care about energy and frequency when you fix the parameters, it's possible to go very high. You can push, for example, the frequency very high. But you need to remember that if you do this, you increase a lot the power. And you need, at some time, you need to consider that it's too much power. And this is probably one of the explanations why recently some people had these problems regarding the Thulium fiber technology. But we will come back on this. So we need to have a look a little bit regarding the past, regarding the Thulium fiber technology. You maybe know that the first time somebody was using the Holmium in the urological field, it's more or less 30 years ago, 1992. And the first publication is done by Johnson, and he published. It's a very nice paper. I like all the time to put this paper as one of my first slides, just to remember the people that you should get this publication just to have a look. And you will be very surprised. You will see that in this publication, Johnson already demonstrates more or less everything that we teach actually in the last 10 years for Holmium technology. You already demonstrate, for example, on this publication that there is no need actually to use the glasses in terms of protection because the risk is almost zero. We can discuss about that. And it's mentioned, it's clearly mentioned in this publication. 1992. If you look some of what he was telling us in this publication, you see that in 1992, he was talking about the contact and non-contact technique. It's amazing, you know, because we rediscussed contact, non-contact few years ago. It comes from some companies like a new beautiful technique to treat stones, to use contact or non-contact laser technique. But it was already described in 1992. All the people completely forget, and then it came back after a long time. He was already talking, as you can see, about the Moses effect. It was mentioned in this original paper. And as I said, if you go in detail in this publication, you will see that he gave excellent recommendation for the setting. He recommends not to use protective glasses, since there's no need for the protective glasses. 2021, so 30 years later, Holmium YAG definitively is the gold standard actually when we are talking about endourology, any kind of stones. We can ablate urothelial tumor, we can treat stenosis, if we have to do endopilotomy, if we have to incise ureteral stricture, if we have to coagulate. I must say that it's not perfect. Coagulation with Holmium is really not so easy, especially if it's a deep coagulation. If it's very superficial, it's possible. But if it's a little bit deep, not so easy. Thulium fiber is probably better actually when you would like to coagulate. And you know that when we are using a very high power system, it's possible to do BPH treatment, what we call the HOLEP procedure. The wavelength, it's in the infrared spectrum. Again, no need to come back on this. You know it's infrared, so we cannot see the laser light when we activate the system. It's completely absorbed in the in fluid, in the irrigation. It's not at the maximum. And we will see that thulium fiber is a bit better for that in terms of absorption. If we come back and just to re-explain what is an Holmium YAG technology, you probably know it's a cavity, completely opaque. It's not really big. You know, if I simulate with my hands, I would say that the cavity is maybe something big like this. So it's not really big, the system itself. The laser system, the machine are relatively big. You know probably it's because of the cooling system. Because when we activate the laser, it's really warm, and you need to refresh the system, and you need cooling system, and the cooling system is big. That's the reason why we have this equipment in the OR. It looks relatively big. And if it's a very powerful system, the system is really big, of course. But this is due to the cooling system. It's not because of this cavity. Again, not really big. Inside the cavity, we put two mirrors at both ends, and one is perforated. And it's possible to close or to open the system. So this is the cavity with the mirror and the opening. Inside the system, to activate the system, we need energy to activate. And to create this, we are using what we call a flash lamp. The flash lamp usually is using a xenolight. The xenolight, you know this kind of technology. That's when we are using a light source. In endourology, we are using this small light source, and it's regularly using a xenolight technology. So we are using this kind of flash lamp into the cavity. And then inside the cavity, we will put a crystal. This crystal, the name is YAG. You know, it's an acronym. YAG means yttrine, alumine, and grenat. It's a very pure crystal. Inside the crystal, it's possible to put some rare elements. You can put, for example, neodymium. And if you put neodymium element inside, you obtain a neodymium YAG laser. If you put thulium, you can put thulium inside, and then you will produce a thulium YAG technology laser. This is one that we know since a long time because the thulium YAG is, as you know, dedicated to treat prostate. It's in competition with Holmium YAG when we do the HOLAP. So thulium YAG, it's a technology completely different than the thulium fiber. It's using thulium both, but not the same technology at the end. And of course, if we put some holmium element inside the crystal, then we obtain holmium YAG laser technology. Now the system is a little bit complex. I'm not sure that we have to go too much in details in terms of physics, but remember that when we activate the flash lamp, we generate light. It's white light, and this light is going through the crystals. The crystal doped with holmium element, and at the opposite side of the crystal, if I make the message a little bit simple, we have one wavelength in the infrared spectrum produced, and that's what we call this holmium YAG laser technology. Due to the mirror, we have some reflection. So the light is going through the crystal in both ways. And there's some kind of amplification of this system. Amplification, this is the A from laser. You know, it's laser is light amplified. So this is this amplification system. So you can imagine that the light is going through the cavity from one mirror to the second one, going through the crystals. So you produce more and more laser lights, 2100 nanometer. And when you reach some level of energy, the cavity open and the light is going outside. And then the cavity, so it goes outside, and then the cavity closes again. So it means that you produce one pulse of energy, laser light, outside the cavity. And when it closed, then the system will restart again to produce exactly the same pulses, and you will have this pulsed light. It's not continuous, going to the surgical fiber, through the surgical fiber. At the end of the cavity, the laser system, we can connect surgical laser fiber. And regarding holmium technology, we can connect different diameters, 200, 275, 365, 550, 800. Some company, they also propose 1000 microns, so it means 1 millimeter. 1 millimeter, it's an equivalent of the size of a safety wire. A safety wire, as you know, or a guide wire, sorry, it's 1 millimeter. So it's possible to have the different size of fiber. To be honest, we don't really need actually 550 or 800. But, I think for endourology, we can use 200, 275 together with flexible ureteroscope. 365 is nice for semi-rigid ureteroscope, but also for mini perc. 365 and 550, it's also good for the regular perc, and 550, that's what we like when we do prostate. So you can make a mix. For example, for me, I'm not doing so many PCNL. I do less than 20, 15, 20 every year. It's really not a lot, PCNL. So actually, I'm using 275 micron fiber since we do actually, when we do PERC, we do mini PERC, and we use the 275 micron, and it works very well. And we don't buy 365. For me, there is no big benefit doing 20 PERC to have this additional equipment. We can do it with the 275. So you can adjust regarding your technique or your personal equipment. The Moses effect, yeah, that's what you see at the tip of the fiber. If you record with a slow motion camera, as you see on this video, you see the transparent tip of the fiber, you see the stone, and you see that when the pulse, the laser light in terms of pulses, are coming at the tip of the fiber, it goes in the irrigation before it can touch the stone. And you see that when the laser light is coming at the surface of the liquid, it creates this bubble, and the bubble will expand because you have energy coming. So the bubble expands, as you can see on the video. And doing that, when the bubble expands, at some time, the bubble make a contact with gas, air, between the tip of the fiber and the stone. So it creates a passage through the liquids. And some of the laser light is able to go through the bubble and now to go on the surface of the stone. And this part of the energy going through the bubble on the surface of the stone will break the stone. But the initial part of the energy create the bubble, and the rest of the energy will go through the bubble to touch the stone and to fragment the stone. And this system, when it was discovered in 1989. So much before the first use in urology, 1982, 1989. And it was described by a guy doing some laser physics. The name is Isner. And he was thinking that this bubble was very comparable to what Moses did. You know, it opened the sea, and then the people were able to go through, to go on the other side. You know the story. So I was thinking it's something very similar, and that's the reason why he called it the Moses effect. 1989. You see Isner, that's the first report. So if you would like to see this report, and you can go to this publication. One of my fellow from Milano, Eugenio Ventimiglia, he published in 2019 a nice paper in the Journal of Endourology where he is talking about the history of Moses effect, Moses technology, and just to make all the story between 1989 until 2019 at the time, to explain the evolutions and what is Moses technology compared to Moses effect. And of course, Moses effect, Moses technology, it's not exactly the same. If we summarize, I can tell you that Moses technology is in fact a very special Moses effect. What does it mean? It means that in 2017, it was introduced, this Moses technology, by Lumenis company. They were able to change the shape of the bubble. You have seen the bubble from the Moses effect. It's something round, it expands, and then it collapses. Lumenis was able, by changing the pulse, to produce a different shape. And when we are looking about the shape, I don't know if the video is working, not sure. No, it doesn't work, I'm sorry for that. But if you look at this video, I can just tell you, the bubble that you will create is not round, it's something more longer. It looks like a funnel. They were able to do that because they modified the pulse. It's what we call pulse modulation. In fact, what they did, they separate the pulse of energy in two pulses, one small before and one bigger behind, coming very close. So the cavity is producing a small pulse, followed immediately by a big one. Why they did it? Because the small pulse will create the bubble to make the contact, and then the second pulse will go through the bubble to go on the surface of the stone. They did this because in the lab, and you see that we are coming back to this discussion with the lab, they realized that doing that, more energy for the same setting in terms of total energy, they realized that if they were able to separate the total energy in two pulses, more energy at the end will reach the surface of the stone. So it means that probably more efficient. If you have more energy going on the surface of the stone, when you produce 1 joule, if you can say that 80% of 1 joule is going to the stone, you are not losing too much to create the bubble. It seems logical to think that you will be more efficient. So this is a reason why they were working on that. And this is from the lab. And from the lab, if you look at the results from the lab, they clearly demonstrate MOSIS technology is superior to the regular mode. We don't know exactly what does it mean regular mode, because you will see a little bit later, we will talk about this pulse duration, could be short, could be long. When we are going in this publication, it's not always completely clear if they compare MOSIS technology to short pulse, regular short pulse, or regular long pulses. And it's maybe one of the reasons about these differences. But when we look at this publication from the lab, fragmentation, dusting was superior by using MOSIS technology. When we are looking, I just summarize with two publications, there's more publications, but if we have a look in the clinical data actually published, it's not so clear. I must say that it's a little bit controversial. Some people, like this one, said there is absolutely no difference, no benefit of MOSIS technology in the real life compared to the regular mode. But if we look other publications, they know there is a benefit, it's going faster, we save time, we have less retropulsion when we are using the MOSIS technology compared to the regular mode. Again, what does it mean regular mode, short pulse, long pulse? Not completely clear. Dr. Manga, you know Manoj Manga from the United States, very well known. When he was looking about the benefit in terms of cost, if it's beneficial to use the MOSIS technology, he failed. And he said, no, there's no benefit. It's too expensive, actually, this technology, to have finally a benefit in terms of cost. It's all the time the question of the cost, you know, in the States, everything is very expensive. It's really difficult to compare, for example, with Europe or Asia. It's different. But at least in the States, he said that there's no benefit, financial benefit, to use actually MOSIS technology. So you see that the technology is interesting, this MOSIS technology, the concept to modulate pulses is interesting. But to be honest, I'm not sure that this is something absolutely fantastic with big differences regarding the regular technology. I can just tell you one point. I'm using this, I have the MOSIS technology in my department. We use it for BPH, for prostate. I must say that I never use it, never to do stones. I use it in the past. I was a bit disappointed, thinking actually there's no benefit compared to my regular Holmium technology when I do flexible ureteroscopy. I'm not talking about PCNL, it's a bit different. With PCNL, you are using bigger fiber, as we said before, and since you are using bigger fibers, You need more energy to keep the same energy density inside the fiber. And since you are using more energy, if you would like to go relatively fast, you have to increase the frequency. So you need much more power. And since you need more power, you need this big technology. But it doesn't mean that MOSIS technology is superior for PCNL, huh? But you need high power system, like this one, for example. Recently, we have seen the MOSIS technology 2.0. To be honest, I have still difficulties to understand what does it mean, 2.0. What is the difference with the MOSIS technology number 1? If you look at the advertisement, you can see that the company said we can go with ultra speed stone dusting at 120 Hertz. I like the sentence. I'm not sure we have the data to support this. Probably, if you go to the lab, you can say that. But I don't think you can say that coming from clinical data, since we have no clinical data. So you see, this is a typical message. Be careful. This is coming from the lab. Doesn't mean that you will be able actually to reproduce what you demonstrate in the lab in the real life. I'm not sure of that, okay? Because to maintain 120 Hertz in the real life, believe me, you need to be a super expert endourologist. Very difficult, very difficult. So be careful. That's my message. If we compare actually in terms of repropulsion, and we did I think a beautiful publication. You can have a look. It's again my fellow Eugenio Ventimiglia. It's published in the PGU 2020. We compare Holmium YAG with the regular pulse, but regular could be short or long, as you know. And we compare with MOSIS mode, MOSIS technology. Then we compare also with Thulium fiber. And you see, it's very interesting to see that for all the settings you are doing, it could be dusting setting, fragmentation setting, it's all the time the same. You see this diagram, it's exactly the same for all the different settings. It's interesting to see that if you compare MOSIS technology with regular mode but short pulse, MOSIS technology is really superior, less repropulsion. Interesting. That's maybe what we have seen in the 2017 publication. But if you compare MOSIS technology now with the regular mode, with the long pulse duration, no more difference, exactly the same. And this is why regularly I'm telling the people MOSIS technology is more or less, it's more or less an equivalent of a long pulse duration. So if you have a system to fix a long pulse duration, you will more or less obtain the same effects than MOSIS technology. And if you compare to the Thulium fiber, and you see this is the blue curve, Thulium fiber is all the time superior in terms of repropulsion. Okay? It's not perfect, but it's much better than Holmium technology. Holmium YAG laser, I put, of course, the picture of the new one from EMS, since you know that EMS is coming actually with Holmium YAG technology since a long time. They were using originally a 20-watt system. Now they are producing 35 watts. It's still a low power system. Only one cavity, laser cavity inside. But it's still low power, but it's possible to produce up to 35 watts. And this is actually what you need to consider as a low power. I see too many times people making comparison with MOSIS technology, for example, or high power system. They compare to low power and they said high power is superior to low power. But when you look at what is low power, they're using 20 watts. And today it's not what we call low power. The standard one in terms of low power is a system like this one, it's 35 watts. And now if you make the comparison between the high power system with the 35 watts, now there's no more difference. So be careful about that. I also seen from one colleague from the UK, last week, we had this kind of discussion, and he said, high power Moses technology is clearly superior, much faster than low power system. But when you look, he was comparing the data. It was a retrospective study, but he was comparing to a previous experience with 20 watts laser. And immediately, you know, the comment is, okay, it's maybe superior to 20, but tell me about 35. Make the same with the 35 watts laser. I can tell you that you will do exactly the same. So very important to remember that. The settings. We talk a lot about the settings since 20 years. I also like to remember the people that when I learned at the beginning, so more than 20 years ago, when I was using laser for the first time, I can tell you that few people were using laser technology, and it was not very clear the way we have to set to use it. And I remember when I was asking some people, big names, I said, but what is the good parameter? What should I fix? And sometimes they said, and you can see this on publications published in 1998, 99, you will see that they were recommended 0.66, 0.6 joules, 6 hertz. And I said, but why 0.6 and why 6? And I remember that some people told me 0.66 because it's easy to remember. That's true. It's very easy to remember, but it was not really based on good evaluation. But it was the beginning of Holmium, so it's normal. In the last 20 years, we learn about these settings in terms of energy, total power, frequency, pulse duration, long, short. We learn how to optimize the use of Holmium. So as you know, if you have a laser, this is the previous system from EMS and the 20 watts system, but I will show you the new one. But the philosophy is the same. So we have three things, three parameters to be fixed. We need to fix pulse duration, and you see on this laser, I like this GUI, this presentation from EMS, because you see short and long, it's really visible. It's two big buttons. So it means that it's important to fix it. And then you have the frequency and energy. So we have 3 points to fix. We need to know how much we have to fix, but we need also to know in which order, which is the first, which is the second, and which is the third one, the last one. Very important also to remember that. This is the new GUI from the new Holmium laser from EMS, the 35. I would say something relatively classical, you know, there's nothing very different if we compare to the different GUIs. But you see that we have still the three possibilities to fix the pulse length, so the pulse duration, then the energy, and then the frequency. I must say that when EMS put pulse duration, energy, frequency, they were using the good order. If you are like me, if you read from the left, from the right, this is the good way, because you have to all the time, when you set Holmium technology, you have to think first pulse duration, then you have to move to energy, and you conclude with the frequency. And frequency should all the time be the last parameter, not the first one. And it comes from what I was telling you before. Remember the formula, energy by frequency and the power. What is important is energy and power. Frequency is not so important. Even since a long time now, we are listening to many people pushing for high frequency, high frequency, high frequency. You probably know I completely disagree with that. frequency is just to accelerate. It's not because you are using more frequency that you will fragment better or that you will produce dust much finer. When the people said that it's best dusting, it's a better dusting, the word better means two things. It means finer or faster. And when they said better dust, in fact, they should say faster, not finer. Okay? And this is some of the confusion actually regarding these high frequency regimes. So energy, that's what is making the job. Huh? If you have no energy, even you put a lot of frequency, if no energy, nothing happens. So energy is the essential, of course. The energy, you know, the unit, it's in joules. It's possible to use low, what we call low energy. Low energy means between 0.2, 0.5, something like that, okay? 0.3, 0.4. If you go more than 1 joule, 1, 2 joules, or maybe more if you're using big fibers, then we said it's high energy. It's a lot of energy. Just to give you some range when we are talking about low energy, high energy. Frequency, it's possible to have low frequency, 1 to 5 hertz. It means 1 to 5 pulses per second. You remember that when we do shockwave litotripsi, we use a very low frequency, 1.5 hertz. It means 1.5 shock per second. When we are using laser, we are using low frequency, 1 to 5 pulses per second. It means 1 to 5 hertz. But it's possible to use high frequency. What we call high frequency, I would say it's something more than 15. If you are using low power system like the EMS1 35 watts, you will be limited most of the time with 20-25 hertz, 20-25 pulses per second. If you're using high power system, 65 watts, 100, 120, 140, it's possible to have much more frequency. So, pulse duration. Pulse duration, as we said before, could be short, could be long. What does it mean? It means this is a pulse. The duration is this small red arrow. It could be very short. It could be long. It means that if it's short, the energy is really high, but you produce the energy in a very short time. For the same energy, if you increase the pulse duration, the level of energy will go down, but it's much more longer. Same energy in total. The only difference is that you distribute, you produce the energy in a very short time. So it's very high, what we call the peak power, or you do something much longer, so you reduce the energy per unit of time, so it's much longer, but the peak power is lower. Same energy, but two different ways to produce. And you see, I put an example. I'm using 5 hertz, 5 pulses per second. You see on the left, we're using short pulses, 5 very short. So in between 2 pulses, we have plenty of time. But if we are using long pulse, okay, it takes more time. So we have a little bit less time in between 2 pulses, and the peak power is lower. 3 parameters: energy, frequency, pulse duration. I already said you have to start with pulse duration. If it's possible with the machine you are using to fix it, do that. Fix the pulse duration first. You need to tell the system, the machine, if you prefer to work to produce short pulse or long pulse each time. So now to talk, I would say in terms of practical, when do we recommend to use the short? When do we recommend to use the long pulse? The short pulse, we recommend more or less exclusively when you do fragmentation. Some colleagues, they also recommend the shock pulse to do the popcorning. To be honest, I did some evaluation in the lab, and we conclude the opposite. In the lab, when we evaluate popcorning technology, it was much better with long pulse. So for me, I keep these results from the lab. I don't know if it's finally the same in the clinical situation, but since in the lab I demonstrate that long pulse when I do popcorning was superior to short pulse, I still recommend to do that, but we can discuss. Long pulse, we recommend to do everything, but not fragmentation. So if you would like to dust, if you would like to decrease retropulsion, as we have seen before, popcorning, if you would like to cut, if you would like to incise, if you would like to ablate urothelial tumor or to coagulate, long pulse. You see, it's very simple to remember. Short pulse fragmentation. If I do something different, long pulse. So you fix it. Then you move to energy in joules. And for the energy, again, you need to know if you need high energy or low energy. Low energy, we need low energy when we prefer to do the dusting. If we would like to fragment, if we would like to popcorning, we will use more energy. If we would like to incise, to ablate urothelial tumor, we also increase energy. And if we would like to make incision, ureteral incision, even more energy. So this is the second parameter. And now you have to conclude with the frequency. And again, remember that the frequency is just the speed that you will go. If you're using low frequency, you are supposed to go slowly because you have few pulses. So you have to wait for the pulses. So of course, maybe you will be very precise because each pulse, you can put each pulse on the surface of the stone, but you go slowly because you have low frequency. If you would like to go faster, if you would like to accelerate, you need to produce more pulses. So then you will go with more frequency. So just keep this message, high frequency. If you are efficient, you are supposed to go faster. I say efficient because think about this situation. I'm into the kidney. My laser fiber is at 1 centimeter from the stone. I'm too far. If I activate my laser, I can put 5 hertz or 10 or 20 or I don't know. All the pulses I produce, I will lose the pulses in the fluid. I will not touch my stone. What I mean is when you are using high frequency, okay, you produce plenty of pulses, but you need to be sure that the pulses are going to the stone. Because if you are moving at the same time and you are far away, most of the pulses, you will lose them. They will not be efficient on the stone. The problem is that if you're using too much frequency, too much pulses, if they are not touching the stone, they will warm the fluids and you will increase the temperature inside. So if you are in a very close location, like a calyx, for example, or a diverticulum, if you're using too much frequency, you will heat the fluid, you will warm the fluid, and the temperature will go very high, super dangerous. So if you are in a closed system, if you have no space, I would strongly recommend to reduce the frequency. If you need to use 1 joule or 2 joules because it's a very hard stone, no problem. But few pulses, low frequency, it will take more time. You will have to be more precise, but it works, okay? Because each pulse, you can direct the pulse on the stone and you're very precise. You don't warm the fluid, you don't damage the mucosa, and at the end, you are efficient. So again, energy is much more important than frequency. Be careful of that. that's what I recommend in terms of parameter. But today, I would say this is not like the only message. This is something I'm using personally, according to my technique. So you can keep it in mind, these numbers, if you like them. You can start with them. But I would say, okay, you need to adapt. Maybe you will not be so happy with what I put on these slides. So this is just to start. You can make a test on the surface of the stone. And if you see that it's okay, you proceed. And if you would like to go faster, you increase the frequency. But if you are not happy, you need to play. And if you play, you have to play with the energy. Because with energy, you will change the effect on the surface of the stone until you're happy. And when you're happy with the level of energy, then you push the frequency to go faster. The strategy, I don't like these debates, you know, when you see in meetings, people say dusting versus fragmentation, what is the best? There's no sense with this debate, to be honest. It was maybe interesting some years ago, but now we need to stop with that. We have different techniques, different tools, dusting, fragmentation, popcorning, and according to each situation, each patient, each stone, talking about the stone volume, the total volume, talking about the stone composition, and it's very important to recognize the stone, to say, okay, this is a very hard one, this is a soft one. It's easy to recognize the stone, actually. So looking at the stone, knowing if it's a hard one or a soft one, knowing the total volume, because we calculate the total volume on the pre-op CT scan, you know which strategy you will use. If it's not too big and relatively soft, okay, you can dust completely the stone. But if it's a big one, mix the stone, hard and soft at the same time, you will have to mix. You'll have to do maybe a little bit of dusting, fragmentation with basketing, come back to dusting. At the end, you have plenty of fragments, so you will make some popcorning. So this is a strategy, and you have to define your personal strategy. I cannot tell you how to do it if you have to do all the time dusting, fragmentation, the way you have to make the combination. This is you. This is your personal technique. You know the three of them, and you make the combination. For laser incision to incise the tissue, that's what we recommend, actually, long pulse, we said.
Olivier?
Yes, please.
There is a question in the chat. I will read it for you.
Okay.
Sorry to interrupt you.
No, perfect.
So I read, this is a question from Simon Nives. Can we have in the future a laser console that have set up with procedures name, for example, dusting, fragmentation, popcorn, ablation, etc., like a car when face a terrain, snow, sand, dust, etc.?
Yeah, I like this question, Simon. It's a beautiful question because it's exactly my philosophy. You know, I like cars. I can tell you, I like sport cars. And as you said, when you drive like this kind of cars, you have different programs according to the conditions, etc. But if you make the comparison with the car, it's not because you set the good program that you will be a good driver. You see what I mean? It's impossible actually to design a console with the perfect setting. And this is one of my messages today, that these pre-settings are very interesting to start, you know, to have some ideas, at least to start, but all the time you have to adapt, you have to change a little bit. So you need to have some range in terms of pre-setting. It could never be a fixed number because it depends on you. It depends on your technique. I give you two examples. If you give me a special setting, let's say 1 joule, 10 hertz, okay. If when I do the case, if the tip of my fiber is in contact or a little bit far away, with the same setting, I produce two different effects, okay? Because the distance between the fiber and the surface of the stone will play a personal role. Second, Second example, same setting. If I'm moving very fast or I'm moving very slow at the surface of the stone. When I'm moving very slow, plenty of pulses at the same place. And I produce something on the surface of the stone. Same setting, I'm moving fast, few pulses. The effect on the surface of the stone is again different. So I cannot tell you here what is the best setting. I can give you some range to say if you're in between this and this is probably okay, but it will completely depend of the technique you are using. And I think this is a message that we learn and we have to give today, that the presetting, they are interesting to give some range, but it will depend from the technique you are using, the quality of the vision, the quality of irrigation, if the kidney is moving or not, plenty of parameters. And in fact, it explains why in the lab we produce results very reliable, because everything is fixed. We change one parameter only. So in the lab, it's easy to demonstrate differences. But in the real life, everything is changing. You know, even you are thinking, I do exactly like for the previous patient. In fact, no, because maybe the stone is different, maybe the distance will not be the same, because the quality of the vision is not good, it's bleeding a little bit. Everything will interfere. And at the end, even you are thinking you have the same setting, you don't produce the same results. So this is actually something we need to understand. I can give you some range in terms of energy, frequency, pulse duration, but you will have to play according to your personal technique.
Okay, thank you for the answer. I think that answers the question quite completely. There was another question from Ahmed Al-Abad. He says, first of all, he thanks you for this amazing webinar. Then his question was, what is the proper way to measure the stone burden?
Okay, very easy. If you ask urologists to say, which formula are you using to calculate the prostate volume? You know, when we are looking from a patient with BPH, they're coming with ultrasound to evaluate the prostate. And as you know, the radiologist, when he do the ultrasound, he measure the length, he measure the second diameter, and he measure the third diameter. And the prostate is more or less something round. It's not a sphere, but it's more or less like stones. So what he do, he takes the three distance, he multiplies together, the three of them, and then he divides by 2, and he obtains the total volume. So just to give you an example with kidney stones, if you take a kidney stones, perfect one, 2 centimeters, and it's like a sphere. So it means it's 20 millimeter by 20 by 20. If you take this formula, it means it's 20 by 20 by 20, it's 8,000 cubic millimeter. You divide by 2, so it's 4,000 cubic millimeter. This formula is coming from the real formula of a sphere. You know this formula. It's 4 divided by 3, multiplied by P, 3.14, multiplied by the radius cubic. If you make some simplification, 4 divided by 3 multiplied by 3.14, 3.14 and 3, it means that it's a 0, so it's 4. So it's 4 multiplied by radius cubic. Radius cubic means radius by radius by radius. 4 means 2 by 2. So now you distribute 2 by radius. It's diameter. And then you proceed 2 by radius. It's again diameter. And now you have still 1 radius. Radius is what? Is diameter divided by 2. So if you make the simplification, it's diameter by diameter by diameter divided by 2. It's for the sphere. The stone, they are not all the time like a sphere. I agree. But we are also not we are not calculating the volume to be very precise for 1 or 2 cubic millimeter. We can estimate. So now the conclusion is, you look at the CT scan, because in the CT scan, it's very easy with no contrast. It's easy to see the stone and to obtain the 3 measures. Since you have the 3 measures, you multiplicate together, you divide by 2, and you obtain the volume. Just to give you some landmarks, if you have a stone of 1 centimeter, the perfect one, 1 by 1 by 1, it means 500 cubic millimeter, 10 by 10 by 10 divided by 2. If you have a stone of 12 millimeter, so it's 2 millimeter more, you can calculate the volume, it's 1,000. It's 2 millimeter more, the volume is the double. If you have a stone of 15 millimeter, it's 2,000 cubic millimeter. So you increase by 3 millimeter more, you again double the volume. If you have a stone more or less 18 millimeter, it's 3,000. And if you have a stone of 2 centimeters, it's 4,000. So you see that you increase the diameter by 10, 12, 15, 18, 20. You are moving from 500 to 4,000. You increase the diameter by 2, 1 centimeter, 2 centimeter. The total volume is moving from 500 to 4,000, 8 times superior. So you realize that total volume is essential. We cannot consider actually a 2 centimeter stone. It doesn't mean nothing to them. And this is regularly when I see some demos, some people said, oh, I did a 2 centimeter stone. I say, come on, it's not 2 centimeter stone. Look at the stone. It's 2 by 1 by 1. If you calculate the volume at the end, 2 by 1, it means 1,000. It's not 2 centimeter. It's a 12 millimeter stone in terms of total volume. And it's completely different. Treating a 2 by 1 centimeter stone with a laser is very fast, because at the end it's 1,000. It's 2 times a stone of 1 centimeter. But if you treat a real 2 centimeter, 4,000, it will take probably, in terms of timing, 8 times more compared to 1 centimeter. Absolutely essential when you do flexible ureteroscopy to calculate the total volume of the stone. You cannot actually proceed with the largest diameter. Otherwise, it's impossible to evaluate what you're doing. Sometimes you will be very happy because you say, wow, I did a fantastic 2 centimeter, but be honest, calculate the volume and you will be very disappointed. The second parameter is, of course, the stone composition. If you have 4,000 cubic millimeter of uric acid, it's going relatively fast. But if you have 4,000 cubic millimeter of calcium oxalate monohydrate, it will take much more time. So total volume, stone composition. For the stone composition, what I do, I respect the unfilled units, 1,000. If it's less than 1,000, I think it's a relatively soft stone. If it's more, it's hard stone. And personally, because I did my own evaluation of what I'm able to do or not, I have different tables with my timing for the operating time. And I know more or less if it's a 2 centimeter stone, soft stone, I will need this time. If it's a 4,000 stone, hard stone, I will need a lot of time. And just to give you the upper limit, when I treat hard stone, so I mean hard stone, calcium oxalate monohydrate, 4,000 cubic millimeters. So it's a real 2 centimeter stone. For calcium oxalate monohydrate, I need personally 2 hours and 15-20 minutes. So if it's this case, I will tell my patients, we will try, I will do my best, but maybe I will not be able to do 1 session. So be aware that maybe I will need 2 sessions. Now, if it's a stone of 4,000, but it's a soft one, I need 1 hour and 30 minutes. And I can tell the patient, we have good chance to do it in 1 session. So it's very important for you to make your own evaluation. You need to know what you are able to produce regarding the stone volume and the stone composition. Ablation for the tumor. Uli, if you can switch off the mic. For the ablation, actually, we recommend long pulse, as we said before, medium energy, 0.5 to 1 joule. Maybe you will say, okay, you recommend from the simple to the double, 0.5 to 1 joule. I will explain why. And for frequency, keep low frequency, 10 Hertz. There's no need to use too much frequency. There's no benefit. It's better to use 10. It's not enough. And be sure that all the pulses are effective on the tumor. Why 0.5? Why 1 joule? 0.5, if you like to touch the tumor. Some people, they like to touch it. If you touch it, be careful. If you have too much energy, it bleeds. So that's why we recommend 0.5. If you prefer to take some distance, that's what I prefer. And maybe you have seen on this video what I'm doing. I touch the tumor to see where is the tumor. Then I go back very far. I activate the laser, and then I'm moving to the tumor. And when I see the tumor with blanching, you see, I activate far away, nothing happened. I'm going to the tumor. When I see that it's becoming white, I stop. I keep this distance. And because I keep some distance, that's the reason I need more energy. I need 1 joule. But you see that doing that, I'm very superficial, and it doesn't bleed too much. And this is one of the tricks to avoid the bleeding. If you're touching too much the tumor, it will bleed. So I really strongly recommend to be a little bit far away, activate the laser, move to the tumor, and when you see that it's becoming white, you stop moving, and you go over the surface, and you will reduce completely, you will ablate completely the tumor by doing that. It works very well. And I can tell you that you can do even big tumor in the collecting system. I do conservative treatment every week. I can really tell you that we do sometimes big tumor up to 2 centimeters. Sometimes when we need to do it, it's not into the guidelines, but special situation, we go even for 3 centimeters tumor. It's feasible if you respect this kind of technique. Holmium, there's a little risk of bleeding, so be careful with that. Low power, high power. We already said, what is the difference between low power, like the EMS, I put 30, but it's 35 watts, compared to the high power? The difference, you see it on this picture. The high power system are using more cavities. It means that for this example, for example, we have 4 cavities. It's possible to have 2, 3, 4. And then you produce high power system. If you're using a low power, like the EMS one, it's only 1 cavity that we already described. But be careful. When you have multiple cavities, like this example, 4 cavities, the 4 cavities are not working in parallel. They are working one after one. So it means it's cavity 1, cavity 2, cavity 3, 4, and then it's coming back 1, 2, 3, 4. It's not 4 cavities at the same time. That's the reason why the level of energy per pulse is the same. Even you are using low power, high power, for each pulse you obtain more or less the same energy. The pulse duration is the same. Even you are using this high power. So what is the only difference? Frequency. You have 4 cavities working simultaneously, so you have more pulses per second. The reason why you are able to go to 80 Hertz, but you have seen with the last MOSIS 2.0, it's even possible to go to 120. The question is, do we need 120? Who is able to use actually all the time 80 Hertz? And what is the benefit of 80 Hertz compared to 20 or 30 Hertz? It's absolutely not demonstrated in the real life. If you go to the lab, no discussion. High power is superior. But now we have to reproduce in the real life. Sometimes I explain this to my fellows when they said, yes, but high power, we have more power, more energy. I say, no, it's exactly the same if you compare. Let's come back to cars. If you compare a Formula One with a regular car, high power, low power, you take the two cars and you go to the circuit and you say, okay, let's make a race. This is the lab. You compare the Formula One and the regular car on a circuit in the lab, no discussion. The Formula One is the best. Now you take the two cars, the same one, high power, low power, and now you go to the real life. What is the real life? This is, when I go to India, for example, I love India, and you go to India and you look at the traffic. I think that's the best example, but it's more or less the same in Paris, actually. You put the Formula One and the regular car, one part of the city, and you said, okay, let's make a race, and let's look who will be the first at this point. You all, of course, the results. The two cars, they will more or less, they will arrive at the same place at the same time. So what you need to remember when we do flexible ureteroscopy, when we are using high power, low power, these big discussions again. First, when you compare low power, use 35, not 20. Second message is that with the low power system, if you are using a low power system, be happy. And don't think, I'm using just a low power system, I'm not doing a good job. You are doing an excellent job. You do exactly the same job than the people using high power system. And of course, with the high power system, I can tell you that they pay a lot for the high power system. But there's no benefit in terms of clinical data when you do flexible ureteroscopy. Remember what I said before, when you do PCNL, since you need much more energy, total power, in fact, you need high power system. I agree with that. But for flexi ureteroscopy, no way. And to demonstrate that, because maybe you are thinking, okay, but Traxer, he doesn't like high power system. No, we look at the publications. 23, we recently published, it's again Eugenio, it's a very productive fellow, as you can see. It's published and it's not in press anymore. 23 publications, people using low power, people using high power. And we look at the results, what is published? If you look at complications, no difference. You don't generate more complication because you are using low or high power. Okay, good point. What about stone-free rate? The same. So you will not obtain best stone-free rate because you are using high frequency. No way. Look at the publication, the real one, no difference. Stone-free is the same. So let's look about the operating time. Interesting. If you look at that, you see that people using high power, they report shorter time, more or less 2 times shorter. For the people using low power means low frequency. Huh? High power means high frequency. So people using these high frequency regimes, it seems they are going 2 times faster. So maybe they're right. But in fact, no, they're not right. Because if you look in this publication and you look at what about the total volume, the volume of the stone they were treated, it's like this, it's a coincidence maybe, but if you look the total volume of the people using low power compared to the total volume of the stone for people using high power system, you just realize, look at that the stone volume is more or less 2 times bigger for the people using the low power system. So what does it mean? 2 times faster, yes, but the volume is 2 times smaller. So if you adjust regarding the stone volume, there's no more difference. So this supposed benefit to go faster, it doesn't work. Again, keep this in mind. If you are using a low power system, you are not doing better. You are doing the same. And if you're using a high power system, maybe you are thinking you are doing the best job, but in fact, no, you do exactly the same job. So you are not doing better, you do the same. And I think it's very important to know actually, because to me, there's too many marketing actually messages, and I think it's not honest with you as a customer when you are looking to buy a low power, high power system. If you don't do PCNL, if you don't do HOLEP procedure, there's no need today to go for a high power system. You can keep a low power. You will do all the business into the upper tract retrogradely using semi-rigid or rigid in a fantastic way, doing the same job. You need to be convinced about that. So do we need high frequency, so high power system? For retrograde intrarenal surgery, definitively no. And I'm still waiting, I can tell you honestly, I'm still waiting the clinical data. I'm not talking about the lab. I'm still waiting the clinical data published by the people using high power, high frequency system, even that they are using Moses technology or not. I'm still waiting. I can tell you personally, I published my data. So you can have a look of what I'm doing. This is my clinical data. And I'm not sure we will get, to be honest, the clinical data of some experts. But for the PCNL, I said we have, maybe we need. I agree that if you do PCNL and if you do prostate, BPH, yes, you need high power system. Okay, I think it's a long overview about Holmium, but I think it's very practical, what I'm telling you today. We need also to consider, after more than 20 years, what we do with Holmium, what we are thinking about Holmium. We are very happy with Holmium. And I must say that when we discuss in between us, we still complain about two problems. One problem, it's time consuming. We need to admit, when I'm telling you that treating a 2 centimeters calcium oxalate monohydrate, I need 2 hours and 20 minutes. Okay, it's too long, it's too long. We don't like it. We really would like to go much faster. But today, I have no idea what can I do to go faster with my Holmium. It doesn't work. Second problem is, even the people say, oh, I dust the stone, I make dust. Okay, but when you look at the results, to be honest, most of the time, it's not really dust. We need to be honest. It looks much more like small pieces, small, tiny fragments, but this is not what we call the dust. The dust, you know what is dust. You go on your face and you do like this and you say, okay, there's some dust. Okay, this is not exactly what we produce. We need to be honest. It's very tiny fragments, but it's not dust. And when you look at the results in terms of spontaneous evacuation of this supposed dust, it's not very perfect. It looks much more like the results of shockwave litotripsi. When we complete the fragmentation, we have the same problem. We have small pieces who stay into the kidney, doesn't evacuate. So it means that they are not small enough, actually. We need really to go finer. And to go faster, it would be fantastic. But if you think about to go finer, to go faster at the same time, there's something wrong. It's difficult to produce something finer and at the same time faster. Because if you go finer, you are supposed to spend more time. So if you spend more time, you are not going faster. So it's something, it doesn't go in the same way, finer and faster. But that's what we need. We need to go finer and we need to save time. To go finer, what can we do to go finer? There's a very simple, first, we like to go finer because you have seen this kind of view in the real life, that at the end of the surgery, you produce fragments, small one, and some dust. The dust evacuates. You see at the end, you have plenty of dust into the ureter, into the bladder. So it means that the dust evacuates easily. But you don't see plenty of fragments into the ureter, into the bladder. The fragments, they stay into the kidney. So we understand easily that if we can produce really fine dust, as you can see on these videos, good chance to evacuate immediately or maybe few days after the surgery. It's interesting to see that when we are leaving a patient with all this dust, if we are coming back for a second session after 1, 2, 3 weeks, we see fragments, but we don't see dust. Most of the time, the dust evacuates because it's very light, it's floating. So this is what we are looking. The second point, if we're able to produce exclusively the dust, as you can see on these videos, you easily understand that we can aspirate. We don't need a big system, a big tube to aspirate actually the dust. So plenty of dust will evacuate, and the rest of the dust, maybe we can aspirate. So this is the concept. Now we need, so that's a nice concept. The problem is that if we are looking about what is the definition of dust, what does it mean dust? Fragments, it's easy. You say less than 2, less than 3 millimeter, less than 5, less than 1 maybe. But dust, when can we say this fragment is so small due to the size that we can call it dust or small fragments? You can have a look in publications. You will not find a clear definition of dust. Okay, all the people say I'm dusting the stone, but when you tell the people, okay, what is your definition of dust? Nobody knows. Or some people said less than 1 millimeter, 0.5 millimeter, but nobody knows. So we were looking about the definition, and I was thinking if we would like to proceed in the experiment, in what we are doing in laser evaluation, we need to have some endpoints. So we make this definition that dust, for me, represents particles less than 250 microns. Why 250 microns? And it was published by my fellow, Dr. Xavier Keller and Dr. De Koninck. They did a fantastic job in the lab, I can tell you. They produced different size of fragments, very, very small, up to 68 micron, 120, 250, 500, 1 millimeter, 2 millimeters, so different size. And they were looking for two things: if it's floating first, and if it's possible to aspirate with a flexible ureteroscope. Making these two commitments, they were able to demonstrate that particles less than 250 are floating, and it's possible to be aspirated with no blockage into the working channel of a flexible ureteroscope. So we decided to keep this definition to make lab experiment. So now we have a limit, 250 microns. The question is, how can we produce smaller pieces? If you have a stone, you have a laser fiber. It's also relatively easy to understand that if you have a very small, tiny laser fiber, the effect on the surface of the stone will be super small. If you're using big fiber, there's maybe more risk to produce big particles. So if you reduce the size of the fiber, you are supposed to produce small pieces. It seems relatively easy to understand. The problem is, if you decrease the size of the fiber, it's a physical effect. You need to use less energy when you decrease the size of the fiber. That's exactly why when we do PCNL using big fiber, we are using more energy per pulse to keep inside the fiber what we call the density of the light. You need to have some concentration of the light inside. We call it density of light. But if you are moving for smaller fiber, then you have to do the opposite. You have to reduce the energy per pulse. Just to give you another example, we compare two fibers, 270, 150 microns. Both of them are commercially available today. The diameter you divide by 1.8. But if you look at the cross section, moving from 270 to 150, you decrease by 3.3. It's a lot. So if you're able to decrease the energy per pulse that you will put inside the fiber by 3.3, you obtain exactly the same energy density. And if you do this, if you make experiments in the lab using two different fibers, the cross-section is 3.3 smaller, you produce pieces 3.3 smaller. So it's demonstrate smaller fiber with less energy inside, you will produce small pieces. So we can go on this concept to say, okay, let's use actually smaller fiber and let's use a system able to produce low energy per pulse. Okay, now to go faster.
Olivier?
Yes.
There is one more question from the audience. It's a question from Mr. Shafiq Memon. He says, or he's asking, is there any role of dust suction in rears?
Of course, and I would say, you know, Shafiq, it's the next step. That's where we are all waiting about that. A good system to aspirate. But keep in mind, Shafiq, that to aspirate, we cannot use a big tube to aspirate. So before we aspirate, we need to produce small pieces, very small, much smaller than what we do today with Holmium. Again, with Holmium, we produce small fragments. We cannot aspirate because the tube will be already too big. It will be impossible to use such a big tube retrogradely. So this is, of course, an excellent question because this is actually the next step. I will not tell you it will be the last step in flexible ureteroscopy, but it will be a huge step. As soon as we will be able to design a system not too big, able to aspirate small particles, it's done. We will go much faster and we will have excellent stone-free rates. So now, PCNL, it will be difficult to maintain the PCNL activities, of course. That's the dream. Huh? But I think it will come relatively soon now, because now we have new technologies to produce the dust, but we have no good technology today to aspirate. You have maybe seen, if you are on Twitter, you have maybe seen one of our Indian colleagues who is super active with the dust suction, and he just, I don't know if we can, all of us, we can do what he's doing, to be honest. But I must say that it just demonstrates it's feasible. He's using Thulium fiber all the time to produce small particles, because you understand that now, coming to the Thulium fiber discussion, the best benefit of the Thulium fiber is that we produce much more dust compared to Holmium, but now we need a system to aspirate. So he's one of the first to report all the time about this dust section during flexible ureteroscopy, and it's very interesting. But we need probably to have something well designed that we can, all of us, we can use it at the end of the surgery to aspirate the dust, or maybe to aspirate the dust during the laser treatment, which would be even much better. Think about the trilogy from EMS. That's what we need, actually. We need a system to break the stone, at the same time it aspirates. It's easy to imagine this. There's no need to be a genius to say, I need something to aspirate. The problem is that we need genius people, very good engineer, to be able to design the system, actually. And it's much more difficult than designing the trilogy system, because we need something very small, very long, flexible, with an endoscopic control in terms of vision. We cannot blindly aspirate, otherwise it will bleed a lot. The mucosa is fragile, and we need to irrigate at the same time. So we need a circulating effect. We need to have a beautiful vision to see what we are doing, where we have to go, the different calyces. The system should be a little bit flexible, and the system should be articulate. So it's a lot of constraints actually to design the system. But since now we produce much smaller particles, dust, real dust, I would say, less than 250 microns, now we can think about special design to make this possibility to aspirate. And I'm very confident, because I trust the engineers a lot. They're fantastic people, and believe me, they will resolve the problem in the near future. I have no doubt about that. So now, to go faster, what can we do? we have to modulate the speed, and to modulate the speed, we need to modulate frequency, as we already said. So we need more frequency actually to go faster. So if I make a summary, what do we need for this concept? We need a new system to go finer and faster, a system able to use very small fiber, smaller fiber than the one we are using with Holmium, able to produce very low energy per pulse to keep the same energy density, and to compensate with more frequency to go relatively fast at the same time. If we apply this concept to Holmium YAG, it seems it's not possible today. We cannot use smaller fiber, it's impossible. We cannot use smaller than 200. It's not possible for Holmium to produce low energy per pulse and to use very high frequency to compensate. So Holmium YAG it seems it's not actually the good technology for the future. It's a good one, but it's maybe not the one for the future. Thulium fiber, it was introduced in 2018. It's a technology very well known since many years, but it was clinically introduced in 2018, in Russia with the Russian colleagues. They were the first to use it, followed by the Indian colleague, and they did a lot in terms of evaluation, clinical evaluation. And now it's available everywhere, in the States, in Europe, in Asia, everywhere. So what is a thulium fiber? Just to remember it's a long fiber. So that's the reason we call it thulium fiber. You remember thulium YAG? YAG, because it's crystal. It's a crystal YAG. But thulium fiber, it's because we're using a fiber. Okay, it's not thulium YAG. It's a long fiber. The internal part of the fiber is really small, but it's completely transparent, 10 microns, and very small inside. So in the middle of the fiber, we put the thulium element, famous thulium element discovered by the Swedish guy. We take this element, we put inside the fiber in the middle, and then we create what we call a doped fiber by thulium ions. This is the representation of this thulium fiber. To activate the laser, we are not using a xenolite like Holmium. We are using multiple diode lasers connect to one end of the fiber to activate the system, to pump the system. That's the name we are using. We pump the system, the laser, the thulium fiber. And when we do this, we produce at the opposite side of this long fiber, we produce pulses of light in the infrared spectrum, not exactly like Holmium. So it's not visible, but it's not the same than Holmium. And that's what we call the thulium fiber laser. If you would like to see some nice animation, you can go on Twitter, on my account, and you will see my fellow Dr. Mariela Corrales. She's with me in Paris. She produced a very nice video just to animate this new system. 2018, so the first thulium fiber was introduced from IPG Medical. The name is the Eurolaze, and it's available in Russia, India, China, I think. Probably it will come in different countries now. Olympus introduced the Soltive Premium, 60 watts, very comparable to the IPG system because they produce this Soltive system together with IPG, introduced in 2020, CE mark, FDA approved. Just followed by this Italian company, Quanta, they introduced the same year, CE mark and FDA, again, the fiberless, it's also a 60 watts thulium fiber system. More recently, it's a very recent, few weeks ago, Olympus also introduced the Soltive Pro. It's a low power system, it's 35 watts. It's more dedicated, I would say, for stone treatments. There's a new software. And to be honest, I did this tweet yesterday because I tested it. It works very well. Huh? The technology, no discussion, it works very well. I was a bit surprised, I must say, by the GUI with the presetting. Some questions, okay? And maybe we will have to to ask Olympus a little bit more why they did these changes. For me, some of them are a little bit difficult to understand. So of course, now the question is, should we compare Holmium high power with the Thulium fiber technology? You know, what I'm telling all the time, I don't think it's nice to compare these two technologies because everything is different. It's much better to compare what we can do with that to compare line by line the specification, because everything is different. The wavelength is the first, of course, Thulium fiber, infrared spectrum, 1940, and you see now we are very close to Holmium, but we are at the maximum in terms of water absorption. Yes, Olivier, tell me, yeah?
Three more questions.
Okay. Oops, I cannot hear you, Uli. You switch off the
sorry,
mic.
I unmuted myself. Sorry. Yeah, there's a question from Mr. Mohamed Guedi. He's asking, is there a relation between dust of stone and infection, especially when dusting infected stones?
So probably Mohamed, I think you're talking about if we generate more sepsis, post-operative sepsis, because we dust compared to fragmentation and to remove the fragments. I don't think we have good data to answer, to be honest. I think the worst parameter actually is the intrarenal pressure. So it means that if you irrigate too much, too strong, you increase the pressure into the kidney, big risk to generate sepsis if it's an infected stone. So if you know it's an infected stone and you can recognize the stone, you know that the patient developed a lot of urinary infection in the past, go slowly, don't spend too much time into the kidney, use a ureteral access sheet to decrease the pressure, and when you irrigate, go gently, don't force the irrigation. This is the main recommendation actually to decrease the sepsis, post-operative sepsis. But I don't think actually we can tell the people that if you dust more, you will generate more sepsis. I don't think so. I remember some years ago a nice publication to demonstrate that when we laser the stone with Holmium YAG compared to the lithoclast from EMS at that time, very efficient. If you treat infected stone, it was really interesting to see that with the laser, you have less bacteria into the urine compared to the lithoclast. And the reason was that the laser, because it's super hot, probably burn the bacteria much more. So at the end, you have residual bacteria, much less with the laser compared to the lithoclast. So just to tell you that laser by itself, because it warms, because it's very hot, probably also participate to destroy some of the bacteria. So the main problem is much more the pressure when you irrigate.
Okay, then two questions from Mr. Andres Puentes.
Okay.
First one is, how do you deal with blurred vision produced by dust cloud because of very high frequencies? And yeah, maybe that question first to be answered, and then I will read the next question.
So you're right that when you go for the dusting, you have this, we call it the snowstorm effect. It's like snow and you don't see very well. It's particularly true if you're using too much frequency. You know, if you put too much frequency because you're very optimistic, then you produce this lot of dust and you have to stop. So you stop the system, you clean a little bit with irrigation, and then you come back. Doing that, you also realize that if you decrease the frequency and you keep constant, you will not have to stop. So at the end, it's more or less the same. Again, if you make the comparison with a car, when you drive a car on the highway, if you put the cruise control and you put 130 kilometers per hour, if you do this in 1 hour, you do 130 kilometers. But if you decide to accelerate and to brake a little bit, and maybe you are going too fast and you are afraid about the police, so you are going slowly and you are going 150, 120, 140, 150, you know this way, okay? If you calculate at the end the average, it's more or less 130. Okay, even sometimes you were going very fast, you compensate, so no big advantage. For the laser, this is the same. If you put too much frequency to go too fast, you will have to stop, and you lose the benefit of high frequency. So decrease the frequency, but keep constant, don't stop, okay? And then you will be as efficient. So this is one of the points to produce this lot of dust. Decrease a little bit frequency, no need to stop, you can proceed, you will be more efficient. The second point for me is when we do the dusting, you need to be super precise. You need to see the laser tip very well. And if you keep the transparent tip of the laser fiber, you cannot see it. Okay, especially if you are using fiber optic endoscopes. If you're using digital, it's better to see perfectly the tip of the fiber. So personally, you probably know, I don't like the transparent tip. At the beginning, I cut the transparent tip. I cut in the blue jacket, and now I see perfectly the blue jacket, the tip of the fiber. So I'm super precise to know exactly where's the tip to go over the surface. Last trick, if you advance too much the fiber in front of the endoscope, irrigation is not able to flush the dust. If you remove the fiber, just what we need in terms of distance from the tip of the scope to the surface of the stone, the irrigation will flush the dust in front of you. If you make a combination of this, you cut the transparent tip, you place the tip just at the right position, you irrigate a little bit to flush the dust, and you don't put too much frequency, you go relatively fast. This is the best way to keep a good speed. What is the good distance for the fiber? When you have the screen of your endoscope, you place the fiber, it comes at 3 or 9 o'clock. You place the tip of the fiber, you consider the middle of the screen, and when you see the fiber to the middle, you put the tip just in between. So it's 1/4 for the diameter of your video screen. If you see the tip at this position, it's not too close from the endoscope, not too far to be efficient with the stone. Keep this distance. Okay, second question, Uli?
Second question. Do you have any experience with new hybrid Thulium yak laser? Actually, the continuous wave for stones? What do you do? Well, and what do you think about it in comparison with Holmium yak laser?
Okay, I think we did an editorial with my fellow recently in the Journal of Endourology. Just to remember, don't be confused, guys. I was a bit afraid when I saw this paper, this publication published in the last January, when the people were talking about the superiority of Thulium laser versus Holmium yak. I said, be careful. When you say that, you introduce some confusion. When you say Thulium laser, you need to be honest, and you should put Thulium yak laser or Thulium fiber if you're using Thulium fiber. Be careful with that. For me, it was a bit confusing. The Thulium yak actually exists. We already know this Thulium yak technology for prostate, as we said before. Originally, like it was designed, it didn't work with stones. So it was fully dedicated for the prostate. A little bit later, so some years ago, it was also possible to use it for urothelial tumor. And now they made some modification of this Thulium yak, and it seems that there's some effects for stone treatment. But I didn't use it, I didn't test it in a lab, I have no experience in the operating theater. So I'm just giving you the information that I have, that I'm not sure actually that the technology like it is today is something that you can use. I mean that if you are looking for this Thulium laser technology, I would still recommend to stay with the Thulium fiber technology and not probably to invest in Thulium yak technology. It's actually available because I don't think it's completely design at the maximum of the possibilities. But this is something very interesting. When I said in my introduction that we have Holmium YAG from the past and now we have Thulium fiber for now and for the future. But in the future, we will have also Thulium YAG technology. No discussion. This is for sure. And Thulium YAG, if we look at what we can produce in the lab, it seems to be a super interesting new technology. So it will come. But today, I would recommend to stay with Holmium YAG or Thulium fiber. Okay, so let's proceed. We still have 10 minutes. The Thulium fiber, you know, people call it the super pulse. You have seen this super pulse. It's a little bit of marketing again. What does it mean, super pulse? When you talk to physicians working in laser technology, they said, for us as engineers, when we evaluate laser in general, pulsed laser, we really like when the pulse is completely constant, very stable, very square in terms of pulse. And you see, I put a video on this slide about the pulse shape of Thulium fiber. And look at the system. It's very square, very stable. It means that if you reproduce the pulses in the time, it's all the time like this, so very stable. So it means that if it's a stable, you are supposed all the time to produce the same effect. And that's what the physicians, they like, because when they do evaluation, they really like to control everything. So they need to have a perfect pulse. If you look at Holmium, it's different. You know, from one pulse to another pulse, the shape is a bit different. It's not all the time the same. So Holmium YAG is definitively not excellent for the physicians because they are thinking that each pulse is a bit different. It's not very stable. The second point is also that at the beginning of the pulse, usually you have what we call a peak power. And the peak power with Holmium is relatively high. It could be 2,000 to 20,000 watts. It's a huge peak power. It's responsible mainly for retropulsion, but also for the burn back of the laser fiber. The Thulium fiber, the peak pressure is really low. It's 500 watts and it's very constant. So this is the reason why the people, they like to call it the super pulse, because the pulse looks like not the perfect one, but something like the perfect one. That's the reason for this name of super pulse. I put, you see, this two pulse shape. You see the Holmium, and you see it's not completely constant. There's some variations with the initial peak power. You cannot see the limit, but the first, the beginning of the pulse is going very high. That's what we call the peak power. And you see the one from the Thulium fiber, you see it's very constant, very square, and you see a little bit of peak power, but it's more or less the same than the rest of the pulse. So that's one of the main differences. Laser emission, that's what outside the box, the laser box. So when the laser light is going outside the box, before we connect the surgical fiber, that's what we call the laser beam profile. So it means that the laser light is focused. If you compare the Holmium YAG and the Thulium fiber in terms of laser beam profiles, you see that it's super concentrated with the Thulium fiber, 16 times smaller compared to the Holmium YAG. So you understand easily that it's so small that we can focus the light in very small surgical fiber, 16 times smaller compared to the one we are using with Holmium YAG. So in theory, with the Thulium fiber, it's possible to use super small fiber up to 50 microns. They are not commercially available, but in theory, it's supposed to be. What is commercially available, actually, it's 150 micron for the Thulium fiber. And we did this comparison with another fellow, a French one this time, Frédéric Pontier. He did an evaluation using small fiber, 150 with the Thulium fiber and 270 for Holmium YAG, and it just demonstrates that we are producing much, much smaller pieces. Xavier Keller, he also demonstrated that when we compare Thulium and Holmium, in the same conditions in the lab, we produce 2 times more dust. And you remember the definition of the dust, according to Xavier and Vincent de Coninck, particles less than 250 microns. So if we take this endpoint, thulium fiber in the same conditions, we produce 2 times more dust. And look at the pictures. You see the pictures of the thulium, the dust, huge volume, and the fragments. Look at the very small fragments. They are still small. They are more than 250, but they are relatively small. Look at holmium. We have some dust, similar one, 250, not so much. And look at the fragments. The residual fragments, much bigger. Okay? So this is from the lab, of course. In the lab, many people, and especially the people from Russia, they evaluate the thulium fiber and the holmium yak. All of the people conclude in the lab the superiority of thulium fiber versus holmium for the stone ablation. So it seems that thulium fiber is maybe the solution to go finer and faster, what we were looking for. Less retropulsion, we already talk about that. Even when we compare with the MOSIS technology, thulium fiber, much less retropulsion. And I think all the people using actually the thulium fiber agree to say that less retropulsion with the thulium fiber. And that's exactly the publication I showed before. When we compare these thulium fiber, all the time better than thulium yak. Laser fiber burn back, and you know that the fiber burn back with holmium damage the surgical fiber, so we are less efficient because we damage the fiber. If we compare this burn back effect with the thulium, much less burn back for the thulium fiber, and it's probably due to the difference between the peak power, high peak power for holmium, much lower peak power with the thulium fiber. If we compare the possibility to break the fiber, especially when we are into the lower pole with the fiber completely deflect, it was again another evaluation we did in the lab. It's under publication actually, just to demonstrate that the thulium fiber is super resistant. Even we are using high energy, it's more or less impossible to break the laser fiber, even it's deflect in the lower pole. So it's very interesting actually, because it's one of the problems with our holmium. Temperature change, if we're using the same power on the same way, actually, there's no benefits about thulium fiber and holmium. We increase the temperature in the kidney exactly in the same way when we are using the same total power with the 2 technologies. It was also published that the temperature is completely comparable of what we do with holmium. Just a few messages for the thulium fiber. So we have seen less burn back, less retropulsion, more dust. Everything is on the good side for the thulium fiber. It's a much smaller system. You see this big machine from holmium yak. It's very heavy, big. Thulium fiber is a very small box, 40, 50 kilo max. You can put this on one table if you would like. There's no need for very complex electrical system. We use the regular plug. The one we are using with holmium yak low power, 35 watts. But if you are moving for high power holmium yak, you need a specific system to connect this holmium yak high power system. So this is another benefit. There's no additional cost in DOR. The wall plug efficiency, we know that the technology of holmium is really not efficient, meaning that if you give to the holmium 100% of energy, it just restitutes in terms of laser energy, more or less 1%. 99%, it's overheating. If you do the same with the thulium fiber, efficiency is between 10 to 20%, much more efficient. So it's, I would say maybe we can say that it's more green for the planet. You are using less energy for that. That's the reason why the system is so small with the thulium fiber, because it doesn't heat a lot, overheat. So the cooling system is really small. It's a regular fan. But if you are using a big system, big Holmium system, you need, because you have 4 cavities, it's super hot, you need a big cooling system. And that's the reason why the system is so big when you are using high power Holmium system. The maintenance, Thulium fiber is super robust because they have no cavity, no mirror, no crystal, so nothing is moving inside. So it's much more robust. It means that if you take the box and you shock the box, it still works. There's no problem for that. You cannot do the same with Holmium technology, as you know. We talk about the size, so no need to be back. This is something, it was like a joke, in between one of my colleagues from the US, he was saying that that's the Traxxas challenge. For me, the Traxxas challenge means what I'm telling you just before. You need to evaluate what you are doing personally. Nobody can tell you do this, because it depends on your conditions, your technique, your skills, your equipment. So to evaluate yourself, I would strongly recommend calculate the total volume of the stone. At the end of the surgery, look at the total energy that you used, the joules, and look at the time when you activate the laser from the beginning to the end. With these 3 parameters, total volume, total energy in joules, and the laser time from the beginning to the end, you can calculate these parameters, the joule per cubic millimeter, the joules per second, and the cubic millimeter per second. With this parameter, if you do it all the time, you will see that your technique is improving or not, if you are doing better or not. And you will have your personal data to know what you can propose for the next patients. You can also do the same with different technologies, Holmium, Thulium, and then you compare, and you will see if you're using the same level of energy, if you are going faster, etc. So it's very good tools, actually, to evaluate yourself. And again, I recommend you to do that. And you see, for the Holmium system from EMS, if you go there, at the end, you will see the emitted energy, the total pulses, and the duration. So you get all the data. You already calculate the total volume before. Very easy to make this calculation, super informative, very nice to evaluate the residents, if they're going faster or not, if they improve during the practice. So we published on that. If you would like to see the details, you can have a look regarding these 2 details. And we made a comparison between the lab, where it's exceptional, the results are perfect. That's the lab. We do a second evaluation, this one. Now this is a real life, and we can compare. And when we compare what we do in the real life, according to my technique, what I do personally, if I compare to what my fellow produce in the lab, it's not the same. I can even tell you I'm not close. I see that I can do much better. I can improve still to reach the top of the top, because the top of the top is the lab. Okay. But it's good for me to know what personally I'm able to do. Very nice. I did these 2 cases in one of my last trip in India. I was doing 2 live surgery, one with Holmium, one with Thulium fiber. You see the characteristic of the stones, more or less the same, calcium oxalate monohydrate, as always in India, a lot of monohydrate. I calculate the total volume of the 2 stones. You see the one from Holmium was a little bit smaller compared to the one from with the Thulium fiber. It was more or less an equivalent of a real 2 centimeter stone. You see the pictures. And look at my results. If I look at the results I was using for Holmium YAG and look at the speed, I was treating 0.6 cubic millimeter per second. This is more or less what I'm doing in Paris, more or less, same conditions. Look at my results with the Thulium fiber. I was able to do 0.9 cubic centimeter per second. It means that I was going more or less 2 times faster with the Thulium fiber. It's just an example. I can tell you that I evaluate actually what I'm doing since 1 year with the Thulium fiber. It's exactly this. I'm going more or less 2 times faster actually, using the same technique, same equipment, just by changing the Holmium YAG for the Thulium fiber. You see, and you can have a look. I record some cases from some good colleagues. Look what they're doing. You know, they're doing a stone. The stone, you see the total volume of the stone was 1,300. Look at the total energy they were using, the litotripsi time, and the joules per cubic millimeter. Usually I'm using 18. That's my average. For this case, the colleague was using 26. So it's more or less not the double, but at least 30% more energy. What does it mean? It means that he was producing more energy inefficient. The energy was waste in the fluids. It was not efficient, so no need to do that. You can reduce frequency, be a little bit more precise to be sure that most of the energy is reaching the stones. And if you look at second case, was the same colleague. He did a nice demo. Huh? He finished the case, completely fragmented, perfect. But look, now he was using 30 joules per cubic millimeter. Again, no problem. The result is excellent. It was just using much more energy. No need to do that. You don't need so much energy, actually, to fragment 1 cubic millimeter. In general, we need 10 to 15 joule per cubic millimeter if it's a soft or hard stone. So when you're using 30, you are using really too much. You are losing a lot. Let's go on that. What do we have in terms of clinical experience for the thulium fiber? I must say relatively few publications. We have fantastic publication from the lab to demonstrate that thulium fiber is great. But coming from clinical experience, we have very few. The initial experience was reported by the Russian colleagues, and you can see that they said, using thulium fiber, we are going 2 to 5 times faster compared to Holmium. Okay, something seems to be what we already demonstrate. Personally, we published our initial experience, clinical experience with the thulium fiber, initial 50 patients. What we demonstrate first, if you look at ureteral stone and kidney stones, look at that in terms of settings we were using, but also in terms of time. You see that for the ureteral stone, for the same volume, we are going 2 times faster for kidney stone. So 2 times slowly with ureteral stone. What is the reason? And this is also a very strong message. The message is, into the ureter, we are in a closed space. So don't push too much the setting of the laser. And when I said don't push too much the setting, I'm thinking don't push too much frequency. Most of the time, the stone block into the ureter, they are not really big. So it doesn't take too much time. So there's no need to go faster. Okay, we need to be precise, not to touch the mucosa. Otherwise, we'll damage, we'll burn the mucosa, and it will generate stenosis. We just have to fragment a little bit, few pieces, and that's it. So into the ureter, use very low frequency. It's a strong recommendation. If you're using low frequency, I recommend to start with 10 hertz. If it's going well, if you're in full control, you don't touch the mucosa, you are really precise, okay, increase frequency to save some time. Don't go too high. There's no reason for that. You can modulate energy. If you need more energy because it's a strong stone, you can go with more energy, decrease the frequency. You will have few pulses, maybe more energy, and you will be efficient to do that. Don't be confused. Don't play too much with the frequency, going too high with the frequency into the ureter, or if you are in a closed space like Calicium diverticulum. If you are into the kidney, you have much more space, and especially if you are using a ureteral axis sheath, the backflow is relatively good, so you decrease the pressure, the irrigation circulates, so you don't increase too much the pressure. Yes, you can push more frequency to go faster. And that's the reason why when we published this paper, you see that the time, according to the stone volume, is 2 times faster for Renal stone, because we are going much slowly into the ureter to be efficient, to be precise, to be safe, not to damage the mucosa. And I think this is really important. So it comes to what I was telling you at the beginning. The thulium fiber technology is not dangerous. You need to accept that. It's not dangerous. It's no more dangerous than holmium. The way you are using the thulium fiber is dangerous. So actually, that's the responsibility of, I would say, people like me talking about this technology, but also the responsibility of companies to tell you, okay, this is a beautiful technology, but you need to learn the way to use it. You cannot receive the technology from the company and to say, okay, use it as you would like. No, they have a huge responsibility actually to tell you what is actually the safest way to use this kind of technology. It's very important, actually. And one of the problems, you know, with the thulium fiber, it was introduced 2 years ago. And maybe you know that in terms of regulation, for the companies, when they were introducing new system, no need for good clinical data. The data from the lab were enough to introduce the system into the market. Now it changed in Europe, same in the States, I think, but in Europe, starting this year, if you don't produce clinical data, you cannot introduce the system. So today, it would be impossible actually to introduce a new laser system with presetting, and you have no data behind the presetting. Because when you give this presetting, the people will tell you, but it's based on what? Which the lab, okay, but do you have clinical data to support? So keep in mind this, thulium fiber is not dangerous. What is dangerous is the way you are using the system. Okay, Uli, I think we move a little bit too much. I just 2 cases to show you in terms of video, but maybe
yeah, we have still 2 more questions.
Perfect.
One is
I'm finished in terms of slides.
Good. Okay, then let's take the questions first, and then you can run the videos. Sure. Maybe one question is from Mr. Uday B. He is asking about the comparison thulium yak hybrid laser versus thulium fiber laser. What is your preference? Or which one would you choose in your daily practice, probably?
If I have to choose between what? Thulium fiber and?
The thulium yak hybrid laser.
Today, I said before, I think thulium yak, I'm not sure it's completely well designed at the maximum of the possibilities. We have not enough data actually to know that. So personally, if you're asking me personally, I would not go for the thulium yak, not today. Even the technology is interesting. I think it's very interesting and it will play a role in the future, I think. But today, if you have to make a choice, a selection, I would strongly recommend to go for thulium fiber. Or you can also still use holmium yak. You know, we have good experience with holmium yak. We know exactly what we can do. We know the limits, but we know also what we can do. So holmium yak, it's not something we have to will disappear. You know, we still need holmium, of course. It's a very good tool. But you can, in terms of thulium fiber is probably the good one and not thulium yak at present time.
Good. Then there was one question that came in from the chat. I think it's from Mr. Sayed Alum. He's asking, as the stone hardness increases, it's difficult to have finer dusting effect. And what is then the ideal setting for such very hard stones? Is this something you can recommend?
What did you say exactly? Will you say it again?
He said, actually, it was a statement. He thinks that the stone hardness is increasing.
Yeah.
And therefore it's more difficult to have a finer dusting effect of those stones. And then the question is, what is the ideal setting for such very hard stones?
You know, if you are still using a Holmium YAG, I think you will not be able to dust completely this hard stone like a monohydrate. It's very difficult. We know the limits, you know, and one of the problems is the size of the laser fiber we are using, 200, 270, to be very difficult, very difficult. And with the high peak power of Holmium YAG, you have a lot of retrapulsion, so the small fragments, it's very difficult to be in contact. Holmium YAG, it's really difficult. So I have no specific trick to decrease, to become even smaller and smaller with the Holmium YAG. With the Thulium fiber, I can really tell you that we produce excellent dust, real dust, super thin, even with this hard stone. We use relatively low energy, not so low compared to what we did in the lab, I must say. We use 0.2, 0.3 joules. Frequency depends on the speed, as always, and we all the time we are using short pulse for the Thulium fiber. I didn't mention today, but regarding the pulse duration for the Thulium fiber, it's not so important compared to Holmium YAG. Most of the time, I stay with short pulse, okay, and it's okay for all the applications. So we play much more with the energy per pulse, and we consider the total power, and with some limits. And looking at these limits of power according to the energy we select per pulse, then we obtain some frequency, and then we play with that. Okay, I run the video at the same time, Uli.
Yeah, okay, fine.
So this one, if you would like to see this one, you go on Twitter and you will see it's a very nice ureterotomy that we did. It was a very, very special case, very demanding. It was probably not the best indication. I fully agree. We never do laser ureterotomy for 3 centimeter stenosis, of course. But this case was a very, very special one with no possibility of surgical. That's the reason why we said, okay, let's try if we can do something or not. I must say that it was a beautiful video in terms of demonstration. I would not recommend to do that for 3 centimeters. It was just because for this case, it was absolutely beautiful and visible. I did an endoscopic control for this patient a few days ago, and I can tell you that the result was really nice. It was really open, nicely still, but it's a 3-month period actually. You know, we will have a look. That's the results. You see, that's the endoscopic vision that we did. I must say it was nice. The patient was not symptomatic. You will have a renal scan and a urocity also in September, I guess, or October. I'm really waiting for that and to see if he improves or not. And I will, of course, make a tweet when I will receive the results to show these results. It was just to mention that it's feasible. We can do a nice laser incision using Holmium, using Thulium fiber. Today, I much prefer the Thulium fiber. The precision is really nice. And the same for the urothelial tumor. It's super, super precise. Keep this formula in mind, guys. The joules per pulse and the total power you are using. Consider frequency less. We still listen regularly, people talking about high frequency. Be careful with high frequency. Thank you. Thank you for your attention, Uli. I think
there's one last question from my friend Sudarshan Yavale from India. So he is asking for the lifetime of these Thulium fibers that are generating actually the energy, the Thulium energy. Is there any
you mean the light
already?
You mean the light, this flashing light?
I think he's asking for the fibers itself. What is the lifetime of the fibers? Is there any limit?
Excellent. No, there's no limit. Excellent, because the laser, the burn back, the burn back of the fiber is really minimal with the Thulium fiber. We evaluate this also in the lab, that we are not losing a lot at the tip of the fiber, because the fiber burn back is really minimal compared to Holmium. With Holmium, you know, we recommend some years ago, every 10,000 joules to cut a little bit the tip of the fiber, a few millimeters regularly, 10,000 every 10,000 joules with Holmium. With the Thulium fiber, there's no need to do that. You can keep the tip from the beginning to the end with absolutely no need to cut. So what we do, you know, if we have to remove the laser fiber for any reason, my assistant, he takes the opportunity and he cut 5 millimeters. But if there's no need to remove the laser fiber, we don't cut the tip just to cut the tip. It's really good. And I think that today, to use reusable fibers with the Thulium fiber is probably a good point, because again, they are not damaged cases by cases.
Okay, I think that answers the question, and that brings us to the end of this very, very interesting webinar. I think according to what I see on WhatsApp, the reactions, the feedback, everyone was delighted to be part of this webinar. And yeah, excellent. Thank you so much, Olivier.
My pleasure.
And hope to see you again on this channel.
Okay.
As I gave up the host to you, you have to, and I have no control again about this webinar. You have to close it after we finish here.
Okay, great.
So do me the favor and just end the meeting when we all say goodbye right now. Okay.
No problem. Thank you. Bye. Bye, Uli. Thank you for the invitation.
Bye bye.
Okay. Bye bye. Take care, guys. Bye.